slope, and then here's my venous return curve. And what's really important here is this point right here. So the point where these two intersect, that is known as the steady state. Okay, so that's the intersection point. And I'm just going to highlight it because that's the steady state, okay, intersect. And this state is telling you what the patient's cardiac output is and what their right atrial pressure is. So let's just say that at this point, the cardiac output is 5 and the right atrial pressure is about 0. Okay, so that's at this point, 0, and right maybe here is about 5. Now what I did here is I kind of color coded this to maybe help it make some more sense. So the slope of the cardiac function curve is going to go up with increased contractility. In other words, it's proportional to contractility. It's going to go up with increased heart rate. In other words, it's proportional to heart rate. It's going to go down when the afterload goes up, inversely proportional. So I did that one in red. I did that one in red because they're inversely proportional. When the afterload goes up, the slope of the cardiac function curve is going to go down. Okay. Now the slope of the venous return curve is also inversely proportional to the TPR, which again, the TPR is essentially going to be the afterload. So, one thing you can remember is that, and you'll see this as soon as we go into the next slide, if I change peripheral resistance and or afterload, essentially what we're doing is we're just changing the slope of both of the curves. If the TPR goes up, veins that are in a board two curves, and let's see if we can get a rhythm going as to how we solve. Here's our step. Much about the compensation that the patient might be having. In other words, if one, and how does that impact this curve? Is primarily just going to the point for acute hemorrhage is going to be some pressure as well, because and then our point is here. It still doesn't change the fact that the curve shifted downward and to the left. Okay, so that's the big point. Don't lose the forest for the trees kind of thing on these curves. You're not getting a PhD in physiology. At least most people that take this test are not, right? So you don't have to be so precise. You just have to have the general idea of what's happening. I have less cardiac output. I have less right atrial pressure. I'm losing blood volume. Okay, now if I gave them IV fluids, what's going to happen if I give them IV fluids? Okay, so yeah, so the curve's going to shift upward. Now it's literally just going to do the opposite, because now I have more total blood volume, right? So my point is going to be somewhere up here. We're going to shift up and probably to the right a little bit. Okay, so somewhere around here. It's probably what I would expect if I gave the patient fluids, if I increase their blood volume. And again, you can make up a whole bunch of things. Oh, I gave the patient a bunch of fluids. Maybe that would lower the heart rate a little bit. Sure, it's possible, but don't worry about that. What's the disruption? What's changed? The blood volume, right? Focus on the blood volume and then ask yourself, does your data point make sense? Okay, chronic systolic heart failure. The disruption, primarily, what is it? Systolic heart failure, right? So it's going to be contractility is my number one disruption. Now, again, like I said, be careful. When they say chronic, you're kind of forced into weighing in some of the long-term factors, such as what's going to happen to this patient's afterload over a long period of time, or their total blood volume. Okay, so when you see chronic, make sure that you take some of these compensatory factors into consideration. But the general idea here is, where I would always start is, okay, what's going to happen? I'm going to have a decrease in contractility. That's primarily going to affect the cardiac function curve, right? It's contractility. It's going to affect the cardiac function curve. And we know that it's proportional to the cardiac function curve. So I decrease contractility. So I'm probably going to end up with a curve that looks something like this. Okay, so this is my cardiac function curve. I have some loss of contractility. That's the number one problem. Now, if you do this, that's already going to win you more than half the battle. Okay, because now the question is there any change in the vascular function curve? And in general, they're probably going to end up with a curve. That's permanent. Make sure that you take some of these compensatory factors into consideration. Factors like heart failure, the disruption, primarily, what is it? Systolic heart failure, right? So it's going to be contractility is my number one disruption. Now, again, like I said, be careful. When they say chronic, you're kind of forced into weighing in some of the long-term factors, such as what's going to happen to this patient's afterload over a long period of time, or their total blood volume. Okay, so when you see chronic, make sure that you take some of these compensatory factors into consideration. But the general idea here is, where I would always start is, okay, what's going to happen? I'm going to have a decrease in contractility. That's primarily going to affect the cardiac function curve, right? It's contractility. It's going to affect the cardiac function curve. And we know that it's proportional to the cardiac function curve. So I decrease contractility. So I'm probably going to end up with a curve that looks something like this. Okay, so this is my cardiac function curve. I have some loss of contractility. That's the number one problem. Now, if you do this, that's already going to win you more than half the battle. Okay, because now the question is there any change in the vascular function curve? And in general, there probably is going to be some changes. If it's chronic, the patient will most likely have a higher total blood volume. And, we see that in heart failure all the time. You see peripheral edema, overall higher blood volume, but less effective circulating blood volume, which we'll talk about in the heart failure video, and you probably would also see a higher afterload. So, all those things being said, basically what we're saying is that the mean systemic filling pressure is probably going to be more out here. Okay, it's going to be more out here. The higher afterload will also cause the slope of this to be a bit lower. So it might be something like this. Okay, just drawing out a rough outline here. Your intersection point will probably be about there. So the point here is our overall steady state is shifted downward from the baseline and is shifted to the right. Okay, so that's what you would see in a patient with chronic systolic heart failure. And again, just to write this out, the number one thing to know is that there's a decrease in contractility. That gets you more than half the battle. That tells you that you're essentially moving right. You can figure out the cardiac output is going to be lower. You can figure out you're going to go down, right? You're in chronic systolic heart failure. So that makes it easy. But if you really want to add in some of these variables, you can say, well, technically, I would expect my TPR or my afterload to be elevated. That's going to mostly be due to RAS stimulation, which would also cause an increase in total blood volume. And we'll talk about all this in the heart failure video and the video on RAS system physiology. Okay, but that's the idea. Like I said, if you just figured out that your contractility is lower, cardiac output's lower, I mean, you already know pretty much where you're going to be. Okay, so that's the concept. Now, if I use digoxin, right, that is just going to be the opposite of the chronic systolic heart failure. Okay, so if I increase contractility using digoxin, what's going to happen? If I increase contractility, my cardiac function curve is actually going to go up in slope. Okay, so I'm going to be more over here from my baseline. So I might be right about there. Okay, if I use digoxin, I would expect to shift to the left because of the increased contractility, and I'd be a little bit higher up. I'd have a higher cardiac output. That's where this black curve would be my baseline, right? So I'm crossing my baseline venous return curve with a higher slope cardiac function curve. Again, all of these, remember, are all at intersection points. Okay, the only one that we had to change both curves for so far was the chronic systolic heart failure. Okay, but most of these, you might change a curve or two, but I'm drawing a lot of these at intersections, you can see with my baseline curve. I know this is getting kind of complicated, so why don't we just erase some of these just and start over just so we can see the last two. So again, here's my steady state point, okay? And let's just look at what happens with phenylephrine and hydralazine. So phenylephrine, remember, is going to increase the total peripheral resistance. Okay, it's primarily an alpha-1 agonist. Okay, so it's primarily going to act at the site of these arterioles. And remember that afterload and TPR are actually going to be in both equations for this cardiac function curve and venous return curve. So it's going to lower, if I increase the afterload, remember it's inversely proportional, it's going to lower the slope of both of these curves. Okay, so here's my cardiac function curve. And then my venous return curve, remember, when I change the TPR, it doesn't change the mean systemic filling pressure. Okay, it doesn't change that. It just lowers the slope. And you can see what's happened here. My new steady state, if I give this patient phenylephrine, is going to pretty much be, down maybe a little bit to the right potentially, but it's mostly shifting down because both slopes are changing. Okay, so generally we're shifting in the downward direction, but both slopes are going to change. That's the most important thing to remember. Now, if I give hydralazine and I lower the total peripheral resistance, okay, so if I give hydralazine and I lower the total peripheral resistance, I'm going to raise the slope of both of these curves. Again, not changing my mean systemic filling pressure. So I'm going to end up somewhere up in this region. Okay, so I'm shifting upward. Ask yourself, right, if I give the patient hydralazine, my TPR is going to come down. So I expect the cardiac output to be higher. And so like I said, a lot of this should make some sense. I have some minor changes in the right atrial pressure, but overall, the major change when I give a patient, an alpha-1 agonist, or if I give a patient something that's going to decrease the TPR, the major change should be in the cardiac output. My big takeaways for you are, again, look at the disruption. Just focus on the number one concept in terms of disruption. Yes, when there's chronic conditions, you might have to factor in some compensation to get to the right answer. But to even put yourself in a position to get the right answer, just focus on the disruption and understand the basics of how these curves move. Okay, if you do that, you have 80% of it down. At that point, you just have to ask yourself, does my data point make sense? Take 5 seconds to pause the video, read the question. Okay, so I gave you a pretty hard question, but it's only hard if you don't understand these curves. After watching this video, I hope that it wasn't a 4-star difficulty question. But the reality is many people get this question wrong because it's hard to interpret these curves. Okay, but using some of the tricks we've learned, let's see if we can figure this out. So 67-year-old male with a chronic smoking history is coming to the emergency department, hypotension refractory to IV fluids. That's the problem. Had an episode of syncope at home. Daughter reports he suddenly lost consciousness while watching television. Vitals are significant for a blood pressure of 88/28. So hypotensive, significantly low diastolic pressure. Remember, when you're thinking of diastolic pressure, what are you thinking about? You should be thinking about the afterload. Okay, so a diastolic pressure, remember I talked about this in the last video. Your diastolic blood pressure is synonymous with afterload. As the afterload or the TPR comes down, the diastolic blood pressure will come down. If I have massive widespread vasodilation, if I have anaphylactic shock, my diastolic blood pressure should be low. This is a huge discrepancy in the pressure. Now, this is a low systolic, that's a very low diastolic. So that tells me that there's probably some decrease in the total peripheral resistance. The patient also has tachycardia to 124, 18 breaths per minute. Imaging findings reveal an aortocaval fistula. Surgery is performed. Which of the following new steady states are most representative of the acute pathophysiology observed in this patient prior to surgical intervention? Okay, so it's basically asking, this patient developed an aortocaval fistula. Patient probably had an abdominal aortic aneurysm where smoking is a major risk factor. Essentially, what could have happened here, right? And this is this patient's abdominal aorta. Here's some aneurysm, okay? This patient has some aneurysm back here. And then, remember, when we looked at axial imaging, the inferior vena cava runs pretty close proximity to the abdominal aorta. Over time, if this aneurysm is getting larger, it can compress down here on the vena cava, okay? And eventually, into the vena cava from inflammation, fibrosis, etc. And so this blood that's being injected from the aorta or through the aorta can actually make its way here with enough pressure, burst through these two walls, and you end up with an aortocaval, right, for vena cava, fistula. That's what we're dealing with, an aortocaval fistula. Now, when you make this connection, think about your in series and parallel, your circuits. You've just added an entire new pathway for blood to travel down. You've just plummeted the total peripheral resistance, because now blood doesn't have to go through the arterioles. It doesn't have to regulate through this pathway. It can just jump to the venous side where there's very low pressures, which is what most of the blood is going to do. It's going to engorge the venous circulation because of the lower pressure. And that's going to plummet your diastolic blood pressure, which is what we see here. Now, fistulas in general, these AV fistulas, we use them for patients with dialysis, for example. What we'll do is we need a vein that has a little bit higher flow, higher flow rate in the venous circulation. So we'll take an artery and we'll connect it to a vein, and this vein will engorge with blood because a lot of the blood is going to travel back through this vein, and it's going to be moving at a faster rate, which is ideally what we're looking for when we're doing dialysis. We perform AV fistulas in many patients on hemodialysis. Okay, but what's happening in this patient is that to a much more extreme level, because we're talking about the aorta, the vena cava. When I introduce a tract between these two portions of circulation, there's going to be a massive drop in the total peripheral resistance, at least immediately. Now, what would happen eventually in this patient, if we didn't really do anything about this, a lot of the blood that's getting pumped out to the aorta, the left ventricle is going to be working double overtime because it might have even more blood coming back from the venous circulation. It's coming right back. Instead of going to provide this oxygen to the tissues, it's just going to come right back to the heart. Okay, and the left ventricle is going to work overtime. And so this would be a scenario where we have a high output left ventricular failure or high output cardiac failure. That's because we're pumping out so much blood, but a lot of it isn't really getting to the tissues. It's just going through this fistula. If we had a low output cardiac failure, that would be like the systolic heart failure we talked about, where there's systolic dysfunction, but we're just not pumping out very much blood. So that's a low output heart failure versus this being a high output heart failure. Okay, and there's other examples of this, thiamine deficiency, right? We'll talk about that later, but that's what's going on with this patient. Let's get to the curve. E is telling you this is prior to the aortocaval fistula. This was the point the patient was at. So we can pretty much say off the bat, because of this significant drop in total peripheral resistance, that's the major disruption. Remember, I said find out what's the major disruption first. So the major disruption is this drop in total peripheral resistance from the fistula that we formed. So E probably wouldn't be the right answer. In other words, E is saying, look, there's nothing that changed. And that's just not true because we dropped the total peripheral resistance significantly. Now, when I drop the TPR significantly, my slope of the venous return curve should go up. When I drop the afterload significantly, my slope of the cardiac function curve will go up. This is essentially the same thing that happened when I gave a patient hydralazine. Okay, so you can see there's really only one option in this whole area here. There's only one option where our new steady state is formed up here. I have a venous return curve that has a higher slope. I have a cardiac function curve that has a higher slope than my baseline two curves, right? So it makes it so, it's very reasonable to pick A. If you kind of just know what's going on, it really isn't that hard of a question. B isn't even a steady state, right? B is just if I moved along the curve. This would not be the right answer. C is an intersection point, so C is a steady state, but this would be more classic for what? Take a look here. So we dropped the cardiac function curve and we dropped the venous return curve. If I drop both of these curves, what's the major situation that we talked about that would cause a drop in both of these curves? That would be if I gave the patient something that increased the afterload, like phenylephrine, an alpha-1 agonist, for example. That would move this more or less kind of straight downward. Okay, and then D is again not a steady state point. This is the point that we have the mean systemic filling pressures. Okay, this would be if this patient's heart stopped beating. If this patient had no heart rate. The heart rate's 124, so the heart's beating. But if the heart was not beating, okay, this would be the equilibration of those pressures that we talked about, the mean systemic filling pressures. So for those reasons, the answer is going to be A in this patient, and this makes sense. So the cardiac output is going to be much higher. It's a high output cardiac failure. I have to pump a lot of blood. I have way more preload coming back to the heart. I have much higher venous return because I'm ejecting the blood from the aorta right into the venous circulation, going right back to the heart. So it's kind of like this vicious cycle where I have really high venous return, really high cardiac output, and not quite super high right atrial pressures just yet because the heart is able to accommodate this for the time being. But over time, this patient will eventually develop heart failure. And in that situation, this curve will start to move this way as the cardiac output comes down and my right atrial pressures come down from a backup of blood. Okay, that will happen eventually. But because this is acute, right, this just happened. This patient just had an episode of syncope, probably just had this fistula forming pretty recently. So we would expect this to be an acute condition. So it would probably be more in this region. But the point is, we don't even have to make the discrepancy between acute or chronic. There's really only one point in the vicinity of the area that we should be focusing on. That is correct, and that's going to be answer A.